welcome to our lesson on fractures. Fractures are very common. You probably definitely see this in your practice. We see a lot annually in the U.S. You may have had a fracture, or probably at least somebody that you know has had one. I'm just going to go over some of the different types of fractures that there are, so we can define fractures in different ways. So they're either complete or incomplete. Complete means there's a complete break through the bone. Incomplete means it only partially broken. And that could be a green stick fracture, which you see a picture to the right on this slide. Kind of reminds me of in the springtime when you're trying to break a twig and it just kind of splinters. It doesn't break through all the way. That's a green stick fracture. And then a fracture could also be closed or open. So open means it's protruded through the skin, which obviously causes a lot of problems, especially with infection risk, or closed meaning it hasn't broken through the skin. And then it can also be displaced or non-displaced. Non-displaced means that it's in alignment. Displaced means it's out of alignment. And avulsion means there's a little chip of bone that's broken off. Comminuted is a crush fracture, so there's lots of bone fragments. That can be really difficult to treat and causes a lot of tissue damage around that bone. A compression fracture could be from a fall, and that, like in the spine, for example, it has crushed upon itself. A depression could be a skull fracture, where there's a depression in the skull. Oblique is at an angle. A spiral fracture, if you ever see that, the first thing you should be thinking about, especially if you have a vulnerable person at all, is that there's a possibility of abuse. It's difficult to get a spiral fracture just naturally because it's a twisting motion. So definitely needs to be investigated if it's a vulnerable person. And then impacted is when the bone has pushed into itself. So some risk factors, young people are at risk just because, very young people, they're kids, they're clumsy, they're risk takers, they get into accidents. And then older people have these other health factors that put them at risk, and they've also maybe they're on medication that put them at fall risk, or maybe they have osteoporosis, so they have a lot more risk factors. Cushing's disease is something you're going to learn about in Module 3, but that is a risk factor. Osteoporosis we're going over in this module. It means the bones are very porous and brittle, so they can break a lot more easily. They may also have cancer, which is a risk factor, especially if it's metastasized to the bones. And then anorexia is a risk factor, whether it's anorexia nervosa or just poor appetite, where they're not taking in enough calcium and vitamin D to strengthen their bones. So the most obvious clinical manifestation is going to be pain, right? They're going to be complaining of a lot of pain in that area, and you may also see a deformity if there is, if it's a displaced fracture, you'll see that deformity. You may also see some bruising and soft tissue damage. So there are some other things you may see as well. So when we have somebody come in, we definitely need to get a good history, because what we want to know is, was this a result of a trauma? Was it a result of abuse? Or maybe it was a pathological fracture, which would be just a result of a bone breaking as a result of a disease process. So a lot of the hip fractures that we see are pathological fractures. So they're a result of the osteoporosis. They're not traumatic. So sometimes, the fracture caused the fall, not the fall caused the fracture. So that's something we're going to want to investigate a little bit. The definitive diagnosis is going to come through an X-ray, and then if we can't see it on the X-ray, we may also do a CT or an MRI, which will just give us a little bit more of a high-definition picture, and show us those smaller fractures, which may not be as obvious on an X-ray. So to treat fractures, this is either going to be surgical or non-surgical. So if it's non-surgical, we have to make sure that it is an alignment, which is called reduction. So if we have to reduce the bone, that just means we're putting it back into alignment. So if we can do that non-surgically, that's called a closed reduction. Then of course we want to elevate and put ice on so that it can reduce swelling. And then if it's non-surgical, we're either going to put it in a sling, splint, cast, or maybe skin traction, for example, Buck's traction. There's a picture right there of that. We'll go into that a little bit more in depth in class. Surgical management would be maybe an open reduction. So we have to open them up to get that bone back into alignment, and then we have to keep it in alignment with internal fixation, which would be rods and screws, or possibly external, which would be pins, and that's called skeletal traction. So we're also going to go over that a little bit more in class, what's involved with traction and pin care and how to take care of all of that. Lots of complications. So there's possibility for neurovascular compromise from all that soft tissue damage. We also need to think about DVTs. And if you have a long bone fracture, like a femur, you really need to think about the possibility of a fat embolism. That's where the fat escapes out of the bone and gets to the blood, and then it can travel to the lungs and cause a fat embolism PE. That's one of our main concerns when somebody has a long bone fracture. If it's a very traumatic fracture, there's multiple fractures like an MVA, they may go into a rhabdomyolysis, which is when the body's trying to filter out all that myoglobin, kind of gets congested in the kidneys and it can cause kidney failure. So take a look at the creatinine. You also want to take a look at the urine because it may have come out a very dark color as it's trying to process all that myoglobin. If it's an open fracture, you may have some hypovolemia. You also have that risk for infection, right? Especially if it gets in the bone. That's osteomyelitis, and that's very, very difficult to treat. We worry about malunion or non-union if it's a displaced fracture, so then it heals out of alignment and the person will end up with a deformity for the rest of their life. And then another major complication is compartment syndrome. I think of compartment syndrome almost like an internal pressure ulcer where there's so much swelling that the skin can't expand enough to hold all that swelling in, and then it just starts to compress on the tissue, and it can even cause the tissue to die, right? So if you think of a pressure ulcer, the reason that they end up with a wound is because there's no blood flow to that area. So the same thing's happening with compartment syndrome. This is considered an emergency. So the only thing we can really do with compartment syndrome, if it's because there's a cast restricting the swelling, the cast has to be removed. If it's a wrap, that has to come off. If it's none of that and it's just the skin that won't expand to allow for all that swelling, then we're going to need to do a fasciotomy, which is where we make longitudinal incisions in the skin, leave it open to allow for that swelling, and eventually when the swelling goes down, then we can close the skin back up. But again, this is a big infection risk factor. Sometimes this is so emergent that it even has to be done at the bedside. They can't even wait to go to the OR. So just know if you suspect compartment syndrome, you need to make a call right away. So because time is tissue, So again, we're going to talk about this a lot more in class. So come prepared, do your readings, and come ready to answer some questions. And I'll see you there.